We now have two, hopefully very soon commercially available, third-generation EGFR inhibitors, osimertinib and also ruxolitinib. These agents really seem pretty comparable in efficacy, some differences in toxicity. What do you see as potentially clinically significant differences? If you had both available, how would you approach a patient with T790M mutation positive acquired resistance?
So yeah, I was going to say there are similarities as in the T790M positive patients. There are some differences in the negative patients.
And we'll cover that too.
But I do think that I'm going to use their numbers because they're easier to remember the names. 9291 is a little better tolerated in my experience than 1686.
The Clovis drug.
The Clovis drug. I think that for patients who are going to be on the Clovis drug, we're going to have to be very diligent about monitoring their blood sugars because the hyperglycemia is a real toxicity that can be quite significant. Now, 9291 did have more rash, but for these patients, they're used to dealing with the rash. They've had rashes for years because they've been on erlotinib, gefitinib, or afatinib, and even the rash with 9291 is less severe than the first and second generation agents.
Clearly, these agents will do well with their marketed names, given how hard they are to differentiate based on their names now.
They will.
Ben, what do you think here?
Yeah, look, I agree. I think they're both very active. They both have response rates of about 50 to 60% in patients that have progressed on Iressa or Tarceva. But they are different in their toxicities and rash and diarrhea with the AZD9291 compound, which we believe is called osimertinib today, is generally manageable and for patients quite similar to the rash that they might have experienced and diarrhea they might have experienced before or even milder. Whereas hyperglycemia is a completely new toxicity, and I think, again, patients need to be vigilant about this toxicity, and doctors need to know how to manage this toxicity with the use of metformin and monitoring of blood glucose, so it can be a little bit trickier.
I must say that about a year and a half ago when these data were first presented, I thought that managing hyperglycemia with some metformin seemed pretty trivial for cancer patients who have an effective treatment against cancer. But when there's an alternative that doesn't have that, and in some of my patients I've had challenging nausea and anorexia, just diminished appetite, weight loss, fatigue, my experience has been it's not a trivial challenge, at least in a subset of patients. That said, they're both a real advance.